So we are running 15 minutes late, so I think that we should make our best to save some time. So the first speaker is a close friend and collaborator. I have the privilege to present Dimitris Papamichael. I believe that the bigger achievement of Dimitris is the establishment of a public state-of-the-art cancer center in Cyprus. So if you can achieve this in a country with great similarities to Greece, you should be able to talk about the simplicity in colorectal cancer and if the game is lost. Dimitris.
Well, thank you very much, John, for this very kind introduction. I'd like to also thank the organizers for the invitation and also Amgen for their sponsorship of this talk. These are my disclosures. And so this is the outline of my talk. It should come as no surprise that I'll be talking about the use of anti-EGFR agents in the context of metastatic colorectal cancer. And to start with, I'll spend a few minutes talking about sightedness and the update to the ESMO guidelines. Then we will spend a few minutes looking at some of the newer data in BRAF mutant colorectal cancer and the use of anti-EGFR therapy. And then I'll try and really investigate and look at some of the data with you that look at the use of anti-EGFR therapy beyond progression, with challenge, and perhaps try and dissect some of the retrospective data from studies to look at some hints into what's the best sequence for use in the metastatic setting. So sightedness, an issue that has dogged us for the last 3-4 years. I think we can all agree that the clinical benefit for anti-EGFR therapy in the metastatic setting is very well established. As far as the continuum of care is concerned, and we know that the best results we get in terms of survival for these patients is achieved by making the best use of our systemic agents that we have available, have to take into consideration the treatment efficacy, the toxicity profile of these agents, as well as the patient and tumor characteristics. However, we still have a lot to learn in relation to what is the optimal sequence for using these agents. And this is from the latest ESMO guidelines, which I think is a great improvement compared to the previous one. And nowadays, we have come to realize that we need to take into consideration the tumor characteristics, the patient characteristics, and also the treatments that we give and the potential side effects that they might have, and the overall impact that they might have on the patient's and his family's life. So for quite some time we've known that right-sided colon cancers are different to the distal or left-sided ones. And this is by no means an exhaustive slide, but I think it just tells us some of the characteristics, both clinical as well as molecular, that I think differentiate the two groups. One of the problems we have, of course, in terms of collecting data is that the right-sided tumors are a lot less in terms of numbers, so getting hold of relevant information is more difficult. So we've known for quite some time that this right-sided tumors are more likely to present in older ladies, they're more likely to present late because of the lack of symptoms, more likely to present with peritoneal disease, and of course they're more likely to be characterized by BRAF mutations and and so on. So this publication, which came out recently, attempted to try and update the ESMO guidelines in relation to this right versus left issue. And what the authors tried to do was to collect data from a number of different trials, which had, it's fair to say, fairly different characteristics amongst them, and we'll look at the difficulties this has added. But I think overall they have achieved a reasonable consensus. So they looked at trials such as the Crystal, Fire3, Peak, Prime. All these are first-line trials, but there are also some second-line trials in there. The medical oncologist in the audience will recognize the acronyms. But I think what this first slide shows is that in terms of prognosis, it tells us what we've known already, that patients with right-sided tumors do worse than those with left. Now, what about prediction? Can we use the available data to help us predict whether patients are more or less likely to benefit from either anti-VEGF or anti-EGFR therapies? And what this slide suggests is that the patients who have right-sided tumors and are exposed to anti-EGFR agents are perhaps less likely to benefit. However, what it also tells us is that the patients with left-sided tumors, RAS wild type, who are exposed to anti-EGFR agents are indeed much more likely to benefit from this kind of treatment. To confuse the issue, this is a slide on response rate, and what it tells us is that if you want to achieve higher responses, whether it's right or left, you can achieve that with chemotherapy plus anti-EGFR. So this work does have its shortcomings. As I've mentioned at the beginning, it has different kind of trials. Some of them compare chemotherapy to chemotherapy plus anti-EGFR. Some of them compare chemotherapy plus VEGF versus chemotherapy plus anti-EGFR. There are some phase 3 and phase 2 trials there, first and second line, so this is a bit of a hodgepodge of trials. Also, if we were considering a randomized trial here, we would want to have enough power, as little bias as possible, and of course we would want to have proper randomization. And you don't have this because these are retrospective data. Nevertheless, I think the conclusions from the authors are quite reasonable. They tell us that if you want to treat RAS wild-type left-sided tumors, the most appropriate option is chemotherapy plus anti-EGFR antibodies. When it comes to right-sided tumors, what you choose is more of a challenge, and they suggest that we should use chemotherapy with or without anti-VEGF agents. But as I've mentioned before, the difficulty here with the right-sided tumors is the small numbers and therefore less robust statistical data. This slide and the next one is from a voting process that took place during a joint meeting of ESMO and JSO, that's the Japanese society, and Japanese equivalent. So what it shows that if you have RAS wild type, BRAF wild type tumors and they're left-sided, then they all go for doublet plus anti-EGFR. If it's right-sided, they would go for triplet plus beva. And for BRAF mutants, they would all go for triplet plus beva if they want to achieve high responses and therefore cytoreduction. If the aim is disease control, then again the data are pretty much the same as in the previous slide, the voting rather, not the data. So what about BRAF mutant metastatic colorectal cancer and the use of anti-EGFR agents? Well, I think most of you are aware of the fact that BRAF mutant patients do badly. Their median survival is much worse than what one would expect in the metastatic setting with optimal chemotherapy. And they also have atypical patterns of metastasis. They are more likely to present with peritoneal disease, with distant lymphadenopathy, and with brain mets. And one of the other problems we have is that these patients are less likely to be exposed to second or third or fourth line chemotherapy, which is really pretty much the norm for all other patients with metastatic disease. So the ESMO guidelines suggest that if you want to achieve cytoreduction, you should use either a triplet or a doublet plus bevacizumab. And for elderly patients, well, you could use capecitabine plus bevacizumab. But for BRAF mutant, this is what they suggest. Do the anti-EGFR agents work in BRAF mutant metastatic colorectal cancer? This is one of two meta-analyses that I've included in my talk, and I think that the data for BRAF mutant patients are all over the place, and I'm not really confident on the basis of this manuscript to make a decision about using these agents. And this is another similar meta-analysis, which again I think shows that the data are by no means conclusive, and I think the methodology might be a bit difficult to comprehend here. So anyway, during the last ESMO meeting in Madrid, we saw this rather interesting trial. It's a phase 3 trial, phase 2 trial, and therefore it's more hypothesis generating rather than conclusive in any way. But what they used was FOLFOXIRI, so triplet chemotherapy, versus FOLFOXIRI plus panitumumab. And some of these patients had BRAF mutations. 7 patients in the modified FOLFOXIRI plus pani, and 9 patients in the FOLFOXIRI, so tiny numbers. But what they saw in the whole group with the anti-EGFR agent plus the triplet was very high response rate, 86%. So if you really want to achieve cytoreduction, this would be a good option, irrespective of your status. And what is also interesting that in terms of your BRAF mutant patients, you still achieved very high responses with the triplet plus panitumumab. As I said, hypothesis generating, but interesting data nevertheless. So what about continuing anti-EGFR therapy beyond progression? This is something that we've been doing with anti-VEGF agents for quite some time now. Well, if you felt that some of your patients were responding and you wanted to extend the benefit of your targeted therapy, you might want to consider switching chemotherapy. Could this be applied to your anti-EGFR agents in the same way that we've applied it into anti-VEGF agents? Another option would be to re-challenge. And in this setting, as we're going to see in a few minutes, liquid biopsy might come to our aid. On the other hand, if you have overwhelming disease progression with first-line chemotherapy, well, you might want to change everything, including your targeted agents. I think I'll skip this in the interest of time. So this is a trial which was published by my very good friend Harpreet Wassan from the Hammersmith, the so-called COIN-B study. This is the schema of the study. So randomized phase 2, what he chose to do was expose his patients to FOLFOXIRI on-off, 12 weeks on, then on progression FOLFOXIRI for another 12 weeks, and then again the same thing. The second arm was FOLFOX intermittently, but the cetuximab was given continuously. So the suggestion from his data would be that if you were to keep going with your cetuximab, you might do better in terms of both your overall survival as well as your progression-free survival. Another similar in design and concept study which suggests that you might want to continue with your cetuximab or your anti-EGFR agent in general is this so-called Caprigoim study, which was published by Fortunato Giardello. And what they did was they took patients who were given FOLFIRI plus cetuximab in the first-line setting, and then were randomized to either FOLFOX cetuximab versus FOLFOX alone. And the data here also suggests that continuing with the cetuximab may well be benefiting your patients. Some retrospective data from the PRIME and PEAK studies using canakinumab with chemotherapy. These are the baseline demographics and disease characteristics of those studies. I think we'll not stick to that. Essentially, what they tell us now. This is the median duration of therapies in the PRIME with panitumumab 5-FU, 5-FU alone, PEAK, panitumumab 5-FU, Bev 5-FU, and the median overall survival from randomization was a lot better in the panitumumab plus 5-FU arm in both the first and the second line trial. What they looked at was progression-free survival after the start of maintenance therapy, in other words, the continuation of panitumumab. And what they saw was that in both instances, the maintenance did better. And this is the overall survival from randomization, which again confirms this trend. What about rechallenging with anti-EGFR agents down the line? Is it something worth considering? Well, one of the main ways in which anti-EGFR agents develop resistance is through development of KRAS mutation. In other words, by giving your systemic chemotherapy with anti-EGFR, you induce RAS mutations. And this is an interesting graph. What it tells us is that once you've stopped using your anti-EGFR agent, your mutations start dropping. What happens is that your RAS wild-type cells keep repopulating the tumor. And this is a very elegant study which looked at exactly this concept. So by using liquid biopsy techniques. So the baseline is when patients are treated with anti-EGFR agents, and as they are, you see an increase in the RAS mutations. Then at some point, the patients receive second-line chemotherapy, which does not include anti-EGFR agents. And at this point, you see that your RAS mutations start dropping. And at that point, it is the right time to reintroduce your anti-EGFR agent. And this is exactly what they did. And this is again the same rationale, the so-called Santini hypothesis. So if you give your patient a break, you encourage the repopulation of wild-type cells into the patient's tumor. And as you can see in this study as well, you achieve very useful responses up to 50-odd% in patients who were previously exposed with anti-EGFR agents in the first-line setting. This concept has been built in the FIRE4 study, which is the main randomized phase 3 trial in Germany at the moment, where they use a liquid biopsy to track, identify resistance, and when they're going to reintroduce cetuximab plus irinotecan there. There is another Greek trial, for those who don't speak Greek. So these patients receive FOLFOX plus anti-EGFR, then they use FOLFIRI or plus anti-VEGF, and then in the third line setting they use FOLFOX plus panitumumab re-challenge. And this also has a liquid biopsy built in. This is a small study, about 30 odd patients, and it's a proof of concept study as well. So what about this washout period? How long should it be? It seems that the half-life is about 3 to 4 months, and in the FIRE4 study, they consider a 4th month period before re-challenging. So what have we learned so far about re-challenge with anti-EGFR agents? Well, existing studies have been done in selected patients. I think it's fair to say that. But I think in these patients we've seen very encouraging responses. And if there is persistent resistance to EGFR, and this you demonstrate by looking at your RAS mutation content, then re-challenge is probably not the best approach. And the longer you keep the patients on second-line chemotherapy, which does not include an anti-EGFR agent, the more likely they are to respond once again in the third-line setting. What about sequence? Well, we don't have any randomized data in terms of sequence, but we have some retrospective data from some of the panitumumab trials, prime and peak in the first line and 181 in the second line. So these patients were exposed to anti-EGFR in the first line in the experimental arm, and then chemotherapy plus VEGF, or FOLFOX, and then exposed to anti-EGFR in the second line setting. And these are the data. Essentially, you can see that there is some benefit to be had by using your anti-EGFR agents first, rather than your anti-VEGF agents first. So the suggestion is that if it's probably best for RAS wild patients to start off with your chemotherapy plus anti-VEGF rather than your chemotherapy plus anti-VEGF agents. And this is what you can see here. So what can we conclude? Well, I think RAS mutation testing is mandatory, and I hope it occurs across the board in Greece nowadays. And I think it's very useful prior to treating or even retreating patients with anti-EGFR agents. If you have a left-sided metastatic patient, he or she is best treated with doublet plus anti-EGFR therapy. And I think this concept of anti-EGFR treatment beyond progression, although currently under investigation, is at least for some patients, quite promising. Circulating tumor DNA and the use of liquid biopsy to assess patients who might be re-challenged, I think is a useful strategy that I think we are likely to see more of in the future. And sequence studies hopefully will have some results in the future. I'll stop here and thank you for your attention.
Thank you very much, Dimitri. So, I think that the answer is there is no simplicity in colorectal cancer. Every patient is different from the other, and every patient has his or her own tumors, and even not one. So the best way probably is to follow the evolution of cancer cell with the evolution of our treatment strategy. Rethink about lines and re-challenge and all these things. I'm not sure that ctDNA is the best tool. It's easier, but may lead better tools may become available in the future, and we can tailor our treatment in a most effective way. I think that we have a question from Professor Xinos about the right-sided metastatic colon cancer. There is a biology that determines the bad prognosis, or the late diagnosis that is frequent.
I think it's very difficult to dissect one from the other. They're both relevant, and I think the way these tumors develop are very different to the way tumors on the left develop. So you don't have the typical adenoma carcinoma sequence in your right-sided tumors. You have serrated polyps, which do not necessarily have the same or similar natural history to the adenoma carcinoma that you see in the so-called Vogelgram, the way Vogelstein described things. So things may, and this is why colonoscopy has not shown an impact in terms of detecting or preventing right-sided colon cancers, perhaps. The way these patients develop, present is very different. Unless if they go to their doctor and have their hemoglobin checked, quite often they present with metastatic disease. I think all of this together it really defines the picture of why these patients present like this. It's not just the genetics, it's not just the clinical picture, is everything.
But if I may, it's different organs. Embryologically, it's different organs.
Yes.
So I think that we're speaking with two different diseases practically, and as you saw on your slide, I mean, everything all is different.
Yes, although I think the transition from right to left it's not a cut as we have in the embryology. It's much smoother, and you can see this in the way the mutational burden changes from left to right. So I don't know.
But it happens in the whole GI tract.
Yeah.
I mean, everything is smoothly from the one organ to the other.
Yeah. Another issue is that we haven't convincing data about the prognostic significance of sickness stage by stage. And there we may have a lot of clues. We are not convinced that stage 2 patients with right-sided tumors have worse prognosis than patients with left-sided. Actually, they may have better.
But stage 3 may do.
Yeah.
So, yes,
yeah,
very confusing.
Yeah.
And one more comment, if I may, more like a comment. I have the feeling that the two contexts, one is continuation beyond progression and the other one is a challenge. I feel like they are contradictory to each other, because you either need to, on a molecular basis, one says that there is no drug addiction and you can just go on, and the other says no, there is perhaps some drug addiction, then you stop, then the tumor is resensitized. So I was wondering how both can have actually positive results.
Well, I think the results that I've shown are not by any means conclusive. They're mostly phase 2 data. They're just there to really stimulate our thinking and how we might best use these agents.
Okay, so I think that we should have a discussion about BRAF mutated patients, but I prefer to do that after Professor Karamuzzi's presentation. I think that he's gonna give us some more data.